Hi viewers, today let's talk about resective osseous surgery. Osseous means something related to bone, resective means cutting. So here the surgery related to cutting the bone. Whereas additive osseous surgery is also there. That means we are going to add certain material or certain things to increase the height of the bone. That kind of surgery is the additive osseous surgery that we'll discuss later. Today let's talk about resective osseous surgery. So before going into detail about the surgery procedures, everything, you need to understand the classification of bone loss. First, there are different types of bone loss are there. First is the horizontal bone loss. If you see the picture, the bone loss has happened in a horizontal manner. This is the most common pattern usually associated with a suprabony pocket. The attachment loss and bone loss that happens in a uniform rate on majority of the tooth surfaces. So here the bone loss is happen in a horizontal way, whereas if you see the picture you'll understand here the bone loss is happening in a vertical direction. So because of that you can see the hollow trough through the bone that along the side of the bone. So this is like a little oblique direction. That is why this kind of bone loss is known as the vertical bone loss. And the base of the defect located apical to the surrounding bone and accompany an infrabony defect. See, this is the base of the defect this is the base of the defect that located apical to the surrounding bone, and this kind of bone loss usually seen in the infrabony pockets. And other bone type of bone loss is the combination. That means we can see both the horizontal and vertical bone loss in this case. And in the vertical bone loss there is a classification. This classification based on the number of osseous wall present. If you see the picture, this is the there are four different types are there. One is the one wall defect, two wall, three wall defect, and combined osseous defect. One wall defect means defect is happening in the only in the interdental wall, not affecting the other facial or lingual or any surfaces. Whereas two wall defect means interdental wall and the lingual or facial wall affected. Whereas three wall defect means interdental wall, facial and lingual surface also affected. This is the one wall defect, two wall defect, and three wall defect that we need to understand. And next is the other terms you need to understand is about the architecture. The positive architecture, negative architecture, and flat architecture. Positive architecture means the shape of the bone would be like this. Okay, the radicular bone, see here, this is the radicular bone and this is the interdental bone. In the case of positive architecture, this radicular bone is apical to the interdental bone. This is interdental bone, so the radicular bone is apical to the interdental bone. So the pattern goes like this. Whereas the negative architecture means the interdental bone is apical to the radicular bone. Now the radicular bone is here and interdental bone is apically placed. So this is the negative architecture. And flat architecture means so the reduction of the interdental bone to the same height as the radicular bone. So now you can see the structure would be like this. Bone structure would be like this. So this is the terms you need to understand before going into the details of the osseous surgery. And next we'll classify the osseous surgery into two different types. That is the information that I passed just now, that the additive or regenerative osseous surgery is also there. Subtractive or resective surgery is also there. Additive is that we restore the bone to its original level. See here, if you see the picture, this is the vertical bone loss, and here due to this additive osseous surgery, with the help of bone grafts or GTR or anything, and then we add the bone here. So now the bone structure is like this. See, we have already closed the space due to the a different regenerative procedure. Whereas the subtractive or resective osseous procedure that we are discussing now, with the help of osteoplasty and osteectomy, we restore the bone to the level at the time of the surgery or more apical. See here, This is the bone loss, and here we cut this area, we resected this area uh, to the to more of apical level with the help of osteoplasty and ostectomy. These two procedures we do to get a this type of bone. And next we'll understand what is the goal of the osseous resective osseous surgery. The main goal is to reshape the marginal bone and convert the periodontal pocket to a shallow gingival sulcus, so that the patients can clean or can maintain the oral hygiene properly. And if you see the picture, this is a surgery without the correction of the bony deformities, which results in return of the pocket depth. Whereas with the surgery, the new bone margins and the gingival cover result in the physiologic sulcus depth. And some factors we need to consider, that they are the craters and the root trunk types. In the craters, we need to understand whether that is shallow, moderate or deep, and the root trunk also we need to understand how whether it is a short, average or the long type of trunk. And the indications are the one-walled angular defects, inconsistent bony margin and shallow crater formation, reverse architecture, buttressing bone formation, ledges and plateau, percussion defects, crown lengthening for restorative dentistry. You can read this. I'm not going into detail about everything. And the contraindications are the certain anatomic factors, like if the roots are placed very closed to the maxillary ramus, such kind of situation we cannot do this. And we need to consider their age and the systemic health, how they may, the improper oral hygiene and high caries index, extreme sensitivity. These cases we should not do this kind of surgery, especially the extensive bone loss and unacceptable aesthetic result and existing too much of mobility. In these cases we are not supposed to do this kind of surgery. And we have to see the advantage and disadvantage. The advantages are the predictability and complete, the pocket will be eliminated completely, and obtaining the ideal bone form. Whereas the disadvantages are we lose the most of the valuable supporting bone. Then the post-surgical mobility can happen, and gingival recession and lengthy unpleasant post-surgical recovery. These all are the disadvantages of the surgery. And if you see the picture, you will understand which all are the instruments we used in the surgery. And next we need to understand the selection of the treatment technique. If the defect is one wall defect, we can just do the recontouring surgically. Whereas if the three wall defects means we need to do the new attachment, bone reconstruction, everything. Two wall defect means we can do either of these two methods depending on their depth, width and the general configuration. Next we'll see the steps how we will do this procedure. Two types are there. First is osteoplasty. We have to do the osteoplasty, and also we need to do the ostectomy. We need to cut the bone and we need to reshape the bone. First step is the vertical growing. This is, if you see the picture, you will understand that we need to reduce the thickness of the alveolar housing. This gives the continuity of the interproximal surface onto the radicular surface. This can be done with the help of carbide and the diamond burrs. And the indications are, if the bone margins are very thick and then we need to get the access, such cases we can do this vertical grooving. And if the condition is like shallow crater formation and areas that require minimal ostectomy, these cases we can do the vertical grooving. But in the case of closed root and thin alveolar housing, these cases we are not supposed to do this kind of vertical grooving procedure. And after the vertical growing procedure, we need to do the radicular blending. And why we do this radicular blending procedure is that to gradualize the bone on the radicular surface to provide the best results from the vertical growing. And this gives a smooth blended surface for the flap closure. And here we need to do the indications are the shallow crater formation and thick osseous ledges of bone on radicular surfaces, and a percussion involvement class 1 or early class 2. In these cases we can do this procedure. And we are not supposed to do this procedure especially if the radicular bone is thin or fenestrated, and if vertical grooving is very minimal. And next is the next procedure is so now the vertical grooving and radicular blending is over. These two are the osteoplasty procedure, and next we have to cut the bone. That means flattening of the interproximal bone. This requires removal of very small amount of the supporting bone, and this we need to do in the conditions like where the interproximal bone levels vary horizontally, and mostly for hemiseptal defects or the one wall defect. We have to do in these cases, we have to do the flattening of the interdental bone. And the last step is the gradualizing marginal bone. This is the marginal bone, we need to gradualize that. Here the bone removal is minimal but necessary to get sound regular base for the gingival tissues to follow. So these are the steps, 4 steps of the osseous surgery. And after this, so before all this, we have to open the flap with the help of the incision, internal reverse bevel incision we have to give initially, and open the flap, full thickness mucoperiosteal flap. And after that only we need to do all these procedures, and then we have to place back the flap apically. That means apically positioned flap technique has to use in this condition. So flap positioned and sutured to cover the new bone margin, or they may be positioned apically. And how the healing is happening is that after 14 or 21 days only this attachment of flap occur to the underlying bone, and up to 6 months may take up to 6 months to get the complete maturation and remodeling, and we need to wait at least 6 weeks after completion of healing of last surgical area before beginning the dental restoration. So this is all about resective osseous surgery. I hope you understand this. If you have any doubt, you can comment in the comment section. Thank you.